My name's Caroline. I'm one of the speech and language therapists working at the National Hospital for Neurology and Neurosurgery. I'm a specialist in progressive neurological conditions and neuromuscular diseases, and a big part of my job is working on our neuromuscular complex care centre. So I work with adults, and I meet adults with Duchenne when they transition to us from children's services from the age of around 16, 17, all the way up. And I know we're pushed for time, so I'm going to try and be speedy. I can talk fast as I'm a speech therapist. So I'm going to go a mile a minute, and I know I'm sharing the stage this morning with someone talking on bone health and emergency care. I don't know if you're here in the room already, but I do like to chat, so just put your hand up and tell me when you want me to start moving on. This is very much an update of an update that's already been presented, and my last slide has a link to the Action Duchenne Conference's YouTube page from 2018 when the big Standards of Care update was first published. So if we miss anything or we've skipped through it, there's a whole 40-minute talk from my colleague Jodie Allen on YouTube that you can go to if you want some more information and feel this has just been a little bit too whistle-stop. So as SLTs, we work in a really integrated way with our multidisciplinary colleagues, with our service users at the centre of the care. So we're sort of like a big arms around all of our young men with Duchenne who we meet. And management of nutrition is so much more than the ability to chew and swallow. As speech and language therapist, I work with occupational therapists to think about seating, hand and arm function, and how to prepare food and get it from the plate up to the cup and into your mouth. We might consider the impact of scoliosis, spinal rods, positioning, breathing and cough with our physio colleagues, and dietitians, of course, to review the amount of food and drink that's taken in its calories and those nutritional needs. For example, bone and skin health hormones, the impact of steroid treatment, weight management, both in terms of obesity, which we think about quite often in children's care. However, in adults, we often think about it the other way and aren't so worried about weight being on. We don't want to think about undernutrition and weight loss later on. We'll also work with our gastroenterology colleagues and consider the impact of possible non-invasive ventilation use on bloating, acid reflux and indigestion, and slowed transit through the esophagus or the food pipe and constipation. I'm not entirely filling the brief that I was asked to do, as I was asked to talk about swallowing update from the lips to the stomach. But as a speech therapist, I'm just going to move forwards. I'm going too fast. I work looking at the swallowing system at the level in the mouth and the throat. So that's the main areas I'm going to focus on. So why am I here as a speech and language therapist? Well, really, conversations and meal times are a huge part of our day-to-day life. And if we've made it like a pie chart, because we're thinking about eating and drinking, sleeping is around 8 hours of our life. Eating and drinking takes another 1 to 2 hours, and we probably spend around 50% of our day doing some form of communication, whether that's engaging with social media, talking to someone, or thinking about things that we're doing. And then I've put a blue circle around the corner, which is like the plate for our pie, as breathing is something we do 24/7 and we don't stop. But we need to think about how we use our breath with our speaking voices and coordinating our breathing with our swallowing. So I think speech and language therapists have a pretty huge part to play in our young people with Duchenne. The 2010 guidelines were very much around a reactive approach to dysphagia or swallowing problem management, and it was sort of about monitoring symptoms as and when they arouse, and we found them. Sort of things like looking out and waiting for weight loss, prolonged meal times, choking, food left in the mouth, or chest infections, or a change in respiratory function. As a speech and language therapist, I was really excited when the 2018 guidelines were published, as the focus is on earlier intervention, and like my colleagues this morning were talking about in the respiratory and cardiac talks, thinking about looking for problems and finding them before anything significant happens. We want to catch it and be preventative and proactive rather than reactive. So as a speech and language therapist, I'm going to focus on the left-hand side of this column here, thinking about monitoring and the guidelines for monitoring and asking about swallowing problems at every single visit, thinking about access to dietitians and nutritional advice, monitoring of weight and height or alternative measurements. You can do a measurement around the middle of the upper arm circumference and from the shoulder to the elbow as an alternative if that person can't be hoisted for weighing. And we need to do that every 6 months. Think about dysphagia, constipation, acid reflux, or gastroparesis, where that sort of slower transit through the food pipe and through the rest of the system until we excrete it as waste. And annually, we really need to think about the dietetic side, which is something I'm not going to cover because I'm not an expert in by any means at all. And really, once those symptoms of dysphagia, so difficulty swallowing, start creeping in, we want to have full assessment of a speech and language pathologist for Americans or speech and language therapist for UK for swallowing assessment, and that may include instrumental assessment. The North Star Network also published some guidelines for therapists working with Duchenne last year as well. And there were 4 pages of speech and language therapy recommendations in this document, which was huge and very exciting to see, which pretty much builds on what was documented in the standards of care published. Those are your references. So we're taking a proactive approach, looking for problems before they result in an admission or immediate need for management. We're going to assess swallowing function in the early ambulatory phases. Previously, this was always something that we thought about later on. I think particularly as our patients are now moving and we're getting adults coming into adult services walking, we don't want to wait for problems to happen. We want to find them if they're subtle and we can help fix it or help and support sooner rather than waiting for a problem or a crisis. We want this to be repeated every 6 months so that we're monitoring and we get used to the idea of looking for swallowing problems, and so it isn't something scary by the time you transition into adult services because it's in your mind and it's something that we're just thinking about and we're keeping an eye on in the background. And the best way to do this is probably just through screening discussions and potentially early discussion around gastrostomy. There's no right or wrong with gastrostomy and it can feel really scary, but knowing what you think right now and what you think in the future is really important, and thinking about what might change. So when we're thinking about swallowing, we're looking at this swallowing system here. The pre-oral phase is getting your food off the plate to your mouth and lips. And then as a speech and language therapist, I work at the level of the mouth and the throat, or the oral and the pharyngeal stages. And there's an awful lot that goes on at swallowing at the level of the mouth and the throat. We need to close our lips, seal the oral cavity so it's a pressurized system, and get that bit of food or drink from the front of the mouth to the back of the mouth, into the top of the throat, the back of the tongue. Here, squeezes up against the throat wall to act like a pump to push that food and drink down through the throat and then into the food pipe, the esophagus here. While that is happening, our airway here with our voice box and vocal cords on top squeezes tightly closed, and it pulls up and forward out of the way. So the air pipe is fully out of the way by the time food and drink moves through. But we know with muscle weakness in muscle conditions like Duchenne that the muscles here can become weaker over time. So that's the oral phase. That's the pharyngeal or the throat phase of swallowing. And then lower down into the food pipe is your esophageal phase, so swallowing towards the stomach and thinking more about the digestion. I'm going to skip past that because I know we're... So what are the causes of dysphagia or swallowing problems in people with Duchenne? Weakness, as with most of our muscle diseases, in the mouth and the throat. Weakness of the respiratory system. There's some changes in anatomy, and we can see jaw contracture or difficulty opening the mouth very wide. We can see that the tongue is often larger or bulky, and there's malocclusion, or we can sometimes see misalignment of the jaw. So there may be an overbite and underbite, or the jaw, the teeth might not line up. They might be a little bit side to side, and that can all impact on the ability to chew and swallow. There can also be sensory deficits, and we talk about the risk of silent aspiration and residues in the throat. That could be where something has gone down the wrong way onto the air pipe and the body doesn't always recognise that, or the body doesn't always recognise if there's bits of food or drink sometimes left in the throat. This is very common in people with just changes in their swallowing that come on very gradually rather than a sudden change, as the body just gets used to and accommodates for those changes over time. It can be a combination of all of the above as well. Unlike in cardiac and respiratory care from the talks this morning, dysphagia and Duchenne is less researched and we know less about it, but it definitely seems to be less predictable. So we cannot say by the age of 18, 25, 30, these are the symptoms we would expect. And some people who have very profound respiratory involvement have little to no dysphagia or swallowing symptoms, and other people can have more obvious swallowing changes. So it's not quite as predictable as some of the other patterns that we see in Duchenne. So how do we identify this if I'm saying it's not predictable and easy, but we know it exists? There are no validated tools at the moment, and self-reporting seems to be the most accessible way to find it. But if the body gets used to changes in swallowing, it can be tricky sometimes to pick out some of those more nuanced changes that we might notice. So we use other clinical information as well, such as weight, ventilation status, respiratory measures, and hospital admissions. An instrumental assessment is the gold standard of swallowing care. So that might be a camera using nasal endoscopy into the nose and down into the back of the throat to have a bird's eye view of swallowing. We call that a FEES, or a video fluoroscopy, which is a swallowing X-ray. However, they're difficult to access, as you tend to only be able to have them in hospital. In some cases, they're very difficult to tolerate. Having a FEES isn't the most comfortable thing to do, and if you've got a lot of metalwork or scoliosis, the X-ray images may not be useful for us. So it's really important to think about, if we're thinking about using an instrumental assessment, even though it's the gold standard, why are we doing it? What is it going to change? What is going to be helpful? So the clinical questions that I would use in my day-to-day work, I'd be asking to see about any difficulties in chewing. Are the chewing muscles getting tired, or are bits of food getting stuck in the mouth? Is eating and drinking becoming slower and longer? Are you drinking fluids to clear residues out of the throat? Are you finding it more difficult or harder to swallow, or feeling an inability to swallow, or finding difficulties initiating a swallow or getting the swallow to happen on time? Sometimes people will feel food catching in the throat, and those are often those dry, hard, crumbly, chewy or claggy textures, and they might find the need to swallow more than once to clear that through the throat. And we're also looking out for coughing, choking, or throat clearing. So as we talked about before, instrumental assessment, there is no one size fits all. And we like to use it to provide a comprehensive dysphagia or swallowing assessment, and it helps us understand and tailor management to that exact person, so you're getting some bespoke advice just for you on the basis of what we see inside your body. It can give us biofeedback, so we can show you what's happening in the moment and say, can you feel that bit there in your throat? Can you get rid of it and swallow again? It can detect sensory changes, and ultimately, as I mentioned earlier, we need to see if it will change management, and if it won't, maybe we shouldn't be doing it. So these are some of the images from 2 of our patients with Duchenne. We can see on this FEES image, that bird's eye view, this is the airway, the vocal cords, and this is the throat. We can see a little piece of banana is just caught in the throat here. And on this image on the left, that's our video fluoroscopy, our swallowing X-ray, and we can see some of this food here, this black barium with food or drink is caught in a pocket in the top of the throat here, the valleculae that we would see here. So this is why we like to use these assessments, so we can see inside the body. So our first line in management that we would do as SLTs is thinking about compensation. So currently, this is based on our understanding of the swallowing impairments or changes and symptoms reported, and that might be making some food textures easy to swallow. So if things like donuts and those really sticky dry bread textures are always getting caught in the throat, we might think about avoiding or adapting those to something that's a little easier to manage, or adding something like some custard or sauce or cream to make it moister. Therapy and exercise. At the moment, we don't really have any evidence for exercise and helping to get the muscles stronger for swallowing in Duchenne. There's some emerging evidence at the moment around targeting the swallow skill and strength and range of movement. In the Netherlands, they're doing work on looking at chewing gum, and it seems that that's not helping with this chewing strength, but it's helping train skill in chewing and doing better chewing with that practice. And then we also need to think about the respiratory management and thinking about, can we tweak some of our respiratory measures to optimise swallow function, such as using NIV before or during meals, trying different interfaces. At the National, we don't yet have mouthpiece ventilation, but there's some good evidence coming out now that mouthpiece ventilation is easier to help in terms of communication and swallowing in comparison to the masks. But it's much more widely used in Europe at the moment than in the UK, so it's definitely something to look out for for and think about, and keep asking us, because in speech therapy we're getting better at doing research all the time and things are changing quite quickly. So what we're thinking about and saying in terms of exercise being emerging now, in a couple of years we may have much better, stronger answers for what is useful and what isn't. Our second line in management is more around thinking about enteral feeding or tube feeding, and thinking to help if high-calorie diets and oral supplements aren't enough, what else do we need to do to help? This is with the full MDT support around each individual as a person, and it depends on respiratory, cardiac function and their body mass index as a calculator of weight. And it's best to have these conversations early and think about it earlier. And it's still possible to eat as well as having a feeding tube. It doesn't have to be an either or, and it's not the end of eating and drinking. We often think of it as a cheat's way of getting extra calories into the body rather than being the end of eating and drinking completely. That's what a feeding tube looks like. Day to day, we're thinking about our routine monitoring. We use a simple self-reporting tool and some additional tools. We take a measure of tongue strength, peak cough flow and weight, and we reassess these on every 6 to 12 months admissions when our young men come into our NMCCC, and we're looking for any subtle changes that maybe haven't been noticed by each individual, as I didn't notice when I was growing, but I definitely didn't come out at 5'6". And the same as we don't notice small changes happening every day in the body. So we tend to say, not have you noticed any changes in your swallowing, but maybe thinking about, have you noticed any changes in your swallowing in comparison to last year or perhaps a couple of years ago? And if they have, then that might be a good time to think about redoing an instrumental assessment if we need to. Right, to finish off, simple swallowing advice on a day-to-day basis. Changes are slow, we've talked about that already. Think about reporting symptoms. Don't be frightened to report changes in swallow symptoms, as there's always something that we can do to be helpful or think about. Don't be scared of instrumental assessments. It's not revealing a problem and making new problems happen. It's about tailoring information about your own body, and it's easier then if you have all of the facts and the information to make the right choices for you as an individual. Take care to chew food well if you are eating something tough or sticky, and maybe adapt or avoid those tricky or hard foods. You might want to think about moving towards blended or liquid foods for some or part of your meals if that's easier to get down, and taking small regular sips of drink when eating can help to clear any residues through the throat. Avoid talking whilst eating, as you're making that part of your body try and do two things at once, and it's breathing all the time in the background as well. And aim to sit as upright as you comfortably can during your meal so that gravity can help pull everything all the way down to your tummy. Give yourself plenty of time at meal times. Don't be rushing. Take as long. It's better to be slow and steady rather than rushing. And instruct people who are helping you on how to best support you. If someone's giving you too large a mouthful or rushing you, tell them to slow down. Tell them what's helpful for you rather than just... It's very strange as an adult to be fed by someone else if you are needing support feeding. So you need to tell the person feeding you what they need to do to help you the best. And the last thing is just to follow the advice from the respiratory therapy team when we're thinking about overall chest health and management. So I'm just going to click to the end. These are the take-home messages from this presentation, and I'm so sorry we've whistled through it at a breakneck pace. Be proactive, preventative and multidisciplinary. We're aiming to prevent the malnutrition and hospital admissions with pneumonia. Be realistic, and it's important as therapists and your whole MDT around you that we help promote your independence and quality of life, and we need to remember to be centred around your personal choice with the full support of a skilled MDT who know about Duchenne muscular dystrophy. Thank you so much for listening. Sorry it's been rapid. If you want more, there's a link here to the Action Duchenne 2018 presentation where Jodie Allen, my colleague and mentor, is talking for 40 minutes around this. And this is my email address on the bottom, and you're more than welcome to ping me any questions if you'd like to talk more. Thank you so much for listening, and sorry it was a real breakneck pace.